Assalamualaikum and a very good morning, everybody. My name is Professor Yoga Yuniadi from National Cardiovascular Center, Harapan Kita, Jakarta, Indonesia. Currently, I am the chairman of the Asia Pacific Heart Rhythm Society Allied Professional Subcommittee. Today, I am pleased to welcome you all to the first Asia Pacific Heart Rhythm Society Allied Professional webinar. We are all facing difficult time in this pandemic situation, but we are not stopping to continue to update our knowledge to be able to give a better healthcare to our patient. So this morning, we are going to discuss all aspects about ventricular tachycardia. This is an interesting topic, I think, that any allied professional who work in cardiology field, especially in arrhythmia field, need to have appropriate knowledge on its epidemiology, mechanism, clinical characteristic, and also management. For those aims, we fortunate this morning to have three distinguished speakers from India, Singapore, and Indonesia. They are all the member of Allied Professional Subcommittee of the APHRS. So before we start the webinar, I can see here we already have about 70 participants. We are going to refresh you all with quiz. Yeah, I have a 5-minute quiz, which comprises of 6 questions that you need to answer. Please answer all the questions. Even if you don't know the answer, you just answer the best thing that you think correct. And we will see the changing of the knowledge after you have you listen to the discussion in this morning. So Jimmy, could you please show the quiz? So here you can see the question, and using your PC or your mobile phone or your device, your gadget, you can choose one correct answer for every question. And you may start now from 5 minutes. Okay, without further ado, let me introduce this first speaker, Dr. Ulhas Pandurangi. Dr. Pandurangi currently is the Chief of Cardiac Electrophysiology and Pacing at Institute of Cardiovascular Disease, Madras Medical Mission, Chennai, India. So in the next 30 minutes, he's going to bring you to understand about the ischemic ventricular tachycardia. If you have any question, just single click on your Zoom screen. You will find QA box at the bottom of the screen. Then when click this box, you will find QA column on the right side of your screen. You may type and address your question there. So I will collect all the question and discuss it during QA session after all presentation. Dr. Pandurangi, you may start your presentation, please.
Professor Yoga, thank you so very much. It's my privilege to be talking to the delegates, and it's such a pleasure and a privilege. Thank you, APHRS. Thank you all the my co-speakers, and thank you especially Jimmy for organizing the whole stuff. So, you know, I'm going to be talking about the ischemic VT today. It's going to be a very brief and a bird view of the whole issue about ischemic VT. So I have some issue here. I would like to bring this thing down. Not sure how to bring it in. Just one second. I am not able to. Yes, I will have to. Sorry for this. Yeah, so ischemic VT is an entity of ventricular tachycardia or ventricular arrhythmias in the context of coronary artery disease. So it is like, you can call it as a VT in coronary artery disease or ischemic heart disease. So they are synonymous. The ventricular tachyarrhythmias are the most feared complications of coronary artery disease. They can cause sudden cardiac death. They are the major contributor to morbidity and mortality. Today, I would consider the scope would be limited to discussion of this ischemic ventricular tachycardia in the setting of acute MI, in the setting of old healed myocardial infarction with or without reduction in the ejection fraction. Ischemic ventricular tachyarrhythmias occurring frequently and within a day times, what we call it as a ventricular tachyarrhythmia storm. And the scope of the discussion would also include some of the therapies like drugs, the revascularization, autonomic tone blockade in the form of stellate ganglion block, or very briefly about the radiofrequency ablation and device, typically the defibrillators in the context of ischemic ventricular tachyarrhythmia. When it is specifically with respect to the acute coronary syndrome or acute MI, one should remember that the ventricular tachyarrhythmia could be the first manifestation in more than half of all cases. And the sudden deaths are most likely due to the acute coronary syndrome, and the precipitating event is the ventricular fibrillation most commonly, especially in the acute phases of coronary syndrome. The 90% of the patients who develop out of the hospital ventricular fibrillation, unfortunately, cannot reach hospital because it requires the therapy within few minutes of the onset of the ventricular fibrillation, which is really not possible currently. And those patients who are lucky to survive such kind of an episode or who did not develop ventricular fibrillation or ventricular tachycardia and acute coronary syndrome, and they happen to visit the hospital, and if they are observed in the CCU, which is the standard norm, up to 5% of such acute coronary syndrome patients may develop ventricular tachyarrhythmias, including ventricular fibrillation. There are many mechanisms why ventricular tachyarrhythmia can occur in acute coronary syndrome, but most common mechanisms are ischemia and reperfusion, which would cause either increased automaticity or increased triggered activity, both the late and the early after depolarizations. The usual form of a ventricular tachyarrhythmia in acute coronary syndrome on the ECG could be described as a polymorphic VT and VF. So this particular picture is trying to explain the commonest mechanisms of a ventricular tachyarrhythmia in acute coronary syndrome: ischemia and reperfusion. Ischemia would lead to shift in the metabolic pathway, causing acidosis. The reperfusion, while washing out the acidosis or the lactate, would also have caused some kind of an abnormal or unfavorable environment. So, and both ischemia and reperfusion would lead to the changes in the properties of the ionic transportation across the cell membrane, and hence change in the action potential curve and leading up to either increased automaticity or triggered activity. There is a different mechanism when there occurs ventricular tachyarrhythmia in an old healed myocardial infarction. On an ECG, typically, the ventricular tachyarrhythmia would appear as a monomorphic sustained wide QRS tachycardia, unlike in acute coronary syndrome, which is a polymorphic ventricular tachycardia. Here, the substrate is the scar, and the mechanism is most likely is a re-entry. Occasionally, even automaticity and triggered activity can also be a part if the old MI patient is also suffering at that time some kind of an ischemic features. The ventricular tachycardia in old myocardial infarction incidence will increase incrementally with the decreasing ejection fraction. So the substrate essentially in old healed MI is existence of a scar, and in the midst of the scar, there is some injured but yet viable tissue, which is described as a channel. And this scar and the channels within the scar are supposedly to be the substrate for ventricular tachyarrhythmia for a re-entry mechanism. So this is a cross-section of a heart of a patient who has developed myocardial infarction. For example, here is a near transmural scar. And if you look at microscopically, and if you make a cartoon out of that, this is telling you the mechanism for the re-entry. There is a scar, and in the midst of the scar, there is a viable tissue, which is injured, and hence the conduction of the impulse is impaired. Typically, the velocity of the conduction is impaired, and this sets the re-entry mechanism. So if there is a scar and then there is a viable tissue, it could exit into the surrounding structure and what we call a single circuit mechanism of re-entry. Sometimes the viable tissue can get exited from multiple sides. For example, here 2 sides, and hence the re-entry circuit could be described as a figure of 8 entry circuit. Sometimes there are multiple ways where the so-called channel, when it is allowing the conduction of the impulse to get exited, so what we call as a labyrinthine kind of a circuit. So this is a scar, and within the scar there is this viable tissue which will make the conduction to go slow, and then that would cause either a single circuit or a figure of 8 circuit, or maybe there are multiple circuits. Depending on that, the morphology of the QRS of the sustained monomorphic VT would change depending upon the amount of the scar, amount of the viable tissues, and the exit sites. The techniques of ablation would change. The role of ECG in the management of ischemic VT is of a paramount importance. The entire diagnosis of ventricular tachyarrhythmia is solely based on what you document on the ECG or some of the event monitoring tools like Holter monitoring or implantable loop recorders. There are sinus rhythm ECG which can give a clue that the wide QRS tachycardia could have been due to the ischemic cause. And those findings during the sinus rhythm, which would help us to think that the wide QRS tachycardia was a ischemic VT, is on the basis of the presence of signs of myocardial infarction. For example, typically the Q waves, the persistent ST segment elevation, secondary T wave changes, loss of R waves, the chamber abnormalities in the form of the voltage changes, frequent occurrence of the PVCs, and some of the QRS characteristics in the form of slurred ascending limb of the R or the S waves, what we call fragmented QRS. If these are the signs during the sinus rhythm, wide QRS tachycardia one could consider the most likely it's ischemic VT. And typically ECG during ECG during a wide QRS tachycardia could be diagnosed on the basis of several of the criteria. But most importantly, if you look at the morphology, it would also suggest where is the site of the exit and less where is the scar. For example, if there was a myocardial infarction, for example, in the inferior and the posterior aspect of the left ventricle, as it is shown in the diagram, a very quick look at the inferior leads, for example, would show the negative complexes. A wide QRS tachycardia with the negative complexes in the inferior leads would suggest most likely the scar is in the inferior and the posterior region, and almost always the exit is in this. So the ECG would tell more of the site of the exit, but indirectly it will tell you the site of the scar. Similarly, if the scar is more in the basal and in the anterior region, you will tend to have the AVF positive. So the so-called inferior axis would tell the scar is, is, is mainly in the basal and the anterior regions. Similarly, if you take the precordial leads, the basal and the anterior regions will tend to have the positive concordance, and if it is apical and posteriorly, that is, you will have a precordial mainly concordantly negative. The general principles of therapy for ventricular tachyarrhythmia would include, typically in acute myocardial infarction, revascularization. That remains the mainstay of therapy, because as we understood, the mechanism of ventricular tachyarrhythmia during acute coronary syndrome is essentially the ischemia, and it is not the scar. So revascularization is paramount importance to prevent and to treat ongoing ventricular tachyarrhythmia. However, revascularization takes a backseat when we are dealing with ventricular tachycardia in an old healed myocardial infarction. Here, it is the scar, as we have understood from the mechanism. Revascularization cannot treat the scar. Revascularization cannot remove the scar, and hence we'll have to adopt different therapeutic approaches. Essentially, automatic implantable cardioverter defibrillators happen to be the mainstay of ischemic VT in old MI, because what is important is preventing the person from developing sudden cardiac death, because there are no other strategies which can guarantee that particular episode of a VT could be treated. You will have to be dependent on techniques like defibrillators. One can also, to reduce the defibrillator functions or number of shocks, one may consider antiarrhythmic therapy. And if still there are ventricular tachyarrhythmias, one may consider radiofrequency ablation. So in acute MI, revascularization is the primary form of therapy. And in the old MI, these ischemic VTs need to be primarily be treated with the defibrillators. Sometimes both acute MI and old MI patients may develop frequent ventricular tachycardia episodes requiring frequent DC versions, which the situation can be very grim, very serious, and that is defined as ventricular tachyarrhythmia storm. Here, the primary aim is to reduce the sympathetic tone, which would include some stellate ganglion block, or maybe one has to resort to sympathectomy. And beta blockers and antiarrhythmic drugs are also a part of so-called empirical therapy. And if still it's not under control, desperate attempts like radiofrequency ablation need to be resorted to. What is the role of electrophysiology study in the management of ischemic ventricular tachyarrhythmia? There is not really a large role of EP study. However, if the patient with a remote MI who has the symptoms which is suggestive of ventricular tachyarrhythmia, for example, palpitations, presyncope, syncope, if that is the symptoms in a person who has had an MI, one should strongly think that that could be a ventricular tachyarrhythmia, because the therapy might require a defibrillator, which is expensive and which comes with its own complications. We need to be very sure that those symptoms are not due to ventricular tachyarrhythmia. To rule in or to rule out, electrophysiology study needs to be performed to prevent sudden death in them. There are situations where you have a patient with the old healed MI, absolutely asymptomatic, but he has some form of a ventricular tachyarrhythmia, either sustained or a non-sustained ventricular tachycardia or a frequent PVCs. And if the ejection fraction is preserved, for example, more than 35% or a 40%, we do not really recommend an AIC in such a patient. But because there were episodes of ventricular tachyarrhythmia in this patient, even with preserved ejection fraction, we have a suspicion that this could be a case for the risk for sudden cardiac death. And there is the role of EP study to see whether in the EP lab, one can induce ventricular tachyarrhythmia. A few lines about defibrillator therapy. Detherapy therapy is expensive, all right, and it has its own complications. However, it takes a major role in preventing sudden cardiac death, because a number of trials both with respect to the radiofrequency ablation and drugs, have shown that the AICD therapy is the only therapy which can guarantee the protection against sudden cardiac death. The AICD therapy can be considered in two headings: secondary prevention, which means the patient already had an episode of a documented sustained ventricular tachycardia, or the patient was resuscitated from cardiac arrest and there was this documentation or a belief that the resuscitation was for ventricular tachyarrhythmia and there are no reversible causes. In such a case, because there is the chance of the person developing the same kind of an event and we should be protecting him from developing sudden cardiac death, ICD is recommended, and such a situation is called AICD therapy for secondary prevention. Sometimes we need to be devising defibrillator therapy even in those patients who never had any ventricular tachyarrhythmia, who never had PVCs, who never had any kind of a sustained arrhythmias, but still if the patient is old MI or 40 days post MI, he continues to have a low ejection fraction, there is this chance that he may develop ventricular tachyarrhythmia and sudden death. So prophylactically, when AICD therapy is recommended, that would be called as AICD therapy for primary prevention. Antiarrhythmic drugs, they complement the defibrillator therapy, but antiarrhythmic solely should not be dependent when you are dealing with a person who has already had ventricular tachyarrhythmia. They are all supplements to the defibrillator therapy. Beta blockers have shown to reduce the events of ventricular tachyarrhythmia. And especially in those patients where the defibrillator is not recommended and the ejection fraction is more than say 40% in them, because there is always a tendency for development of ventricular tachyarrhythmia in ischemic heart disease. The only group of drugs which have shown that the reduction in ventricular tachyarrhythmia is beta blockers. There are certain other empirical drugs which are being tried, but they are all one should remember on top of AICD therapy. In the order of the preferences is usually amiodarone, sotalol, some select cases mexiletine, and very rarely ranolazine could also be considered in the management of these VT with respect to the drug therapy. When a person has an ICD, when a person also has those antiarrhythmic drugs, and if there are frequent ventricular tachyarrhythmia episodes requiring frequent shocks, radiofrequency ablation could be considered as another additional or a complementary therapy. So typically, if the patient has a defibrillator and he has a recurrent VT, or sometimes only one shock post AICD may prompt the physician to consider amiodarone therapy. I would be showing one case example which will summarize the whole concept of what I have been speaking with respect to ventricular tachyarrhythmia in acute coronary syndrome. For example, this is a 63-year-old male who has had old inferior wall MI, and he has had the primary percutaneous coronary intervention to left circumflex artery in the year 2015, and he had a moderate LV dysfunction, ejection fraction about 35%. Now he comes with a ventricular tachyarrhythmia storm. Here is the patient with the old inferior wall MI coming with a VT storm. So there is an element of a scar, and a VT storm is usually one of those reversible causes. Unless proved otherwise, one can consider ischemia is playing a role. So acute ongoing ischemia in an old case of inferior wall MI. So to figure out whether this VT storm could be treated with some revascularization, because ischemia can trigger a VT storm. He undergoes a coronary angiogram, but then there is no treatable coronary artery disease. There was the stent which was occluded, and the interventional cardiologist thought that would not probably be able to be amenable for treatment. And moreover, he also thought that is such a scar that it must not have been, it may not be worthwhile to open the artery. So he was referred to us, and this is the kind of wide QRS tachycardia the patient is having. And in a person who has had a old myocardial infarction or a coronary artery disease, if you have a wide QRS tachycardia, well, we don't waste much time in making a diagnosis, whether it's a SVT with aberrance or a ventricular tachycardia. One should consider this is VT unless put otherwise. In this case anyway, you have a precordial concordance. So this almost makes it as a case of a ventricular tachycardia. And if you look at the algorithm, what I showed earlier, it is telling you the exit is most likely from the basal areas because it is inferior axis, 2-3 AVF tall R waves. So it makes it gives us an idea that indeed that LCX, which was totally occluded, has probably caused the scarred the ventricle at the area where it was distributing, and that was lateral in the basal area. So with that diagnosis, and the patient with the VT storm now requires therapy, and that should be very, very quick and prompt. That would include medical stabilization. And as I mentioned earlier, autonomic blockade is one of the important components, and the patient should undergo one kind of a therapy. For example, the easily bedside available tool is the stellate ganglion block. And if things are not getting stabilized, the plan would be to consider radiofrequency ablation. And because this patient comes with VT storm and there is a LV dysfunction, it is likely that he may develop a VT later. And hence, even if you think he has been stabilized during this admission time, you should be considering the AICD implantation strongly for this patient. So you try to stabilize him with the medications, empirical cocktail of antiarrhythmics, beta blockers, sedation, general anesthesia, stellate ganglion block, etc. If the things continue, you may have to take him for the radiofrequency ablation. And in the EP lab, you can put in catheters inside the heart. For example, here, there's a catheter inside the coronary sinus. What it is telling you that there are low frequency fractionated electrograms in the CS, which is telling you that the scar is in the region of the distal coronary sinus, which is the territory of the LCX. And because this kind of potentials are recorded in the CS, maybe there is some transmural scar extending to the epicardium. This is the way the substrate is mapped. If you have on your multi-electrode channels having low amplitude fractionated signals occupying a large length of time, it tells you wherever these electrodes are placed, maybe that is the area of the scar. For example, here it is what was there in the basal and the anterior area of the left ventricle. 3D electroanatomic mapping helps to a great extent to quickly identify where is the scar by looking at the voltages and then scaling those voltages according to the grid. For example, if this is less than 1 millivolts or less than 0.5 millivolts, that area could be colored as gray, and the surrounding area, which is little more than 1, could be graded as a viable tissue. And then surrounding area, if, for example, here in this color, if it is more than 1.5. So it very quickly with the 3D electroanatomic mapping, one can identify where is the scar, where is the viable tissue, and is the healthy tissue. One can also identify the so-called low voltage fractionated electrograms by again looking at the amount of the duration for which those electrograms are recorded. And that can be corroborated with the electrograms which are obtained from the catheters inside. One can also do some kind of a pace mapping at that area. And if you pace map and if that is telling you that the QRS is similar to that what was there during the ventricular tachycardia obtained on an ECG, maybe it will tell you the exit site. So you are identifying the scar, you are identifying the exit site, and you may look at during the ventricular tachycardia in that particular area of interest, if you are seeing such kind of fractionated electrograms occupying 2/3 or 1/3 of the diastolic component, you probably are in that area of the isthmus, and then you try to give some burns. If it is successfully terminated and if it is not inducible, maybe you have achieved the results. But in this case, it was not terminating, and then we needed to be going towards the epicardium. In the epicardium also you can map easily and then find out if you get again a low voltage complexes, and this is known as an activation map. Depending upon the way the activation is recorded at various sites, you can create isochronal map, which also helps you to tell the direction of the propagation of the wavefront and surrounding which part of the structure the activation is propagated. So these are all the techniques of identifying the scar, the isthmus, and the healthy tissue. And there can be a kind of a graphical representation of all that data, which will give a nice idea about where could be the site of the isthmus through which the activation is propagating. So all these tools are great. And we need to be understanding how do we perform all this. And if you identify the isthmus, delivering the radio frequency energy, and maybe that could save this patient who has had in the VT storm. So what I would like to tell at the end here is the ischemic ventricular tachyarrhythmia is the most feared complication of coronary artery disease. The mechanisms differ with respect to the acute coronary syndrome situation and old healed myocardial infarction. Triggered activity and automaticity are the main mechanisms behind acute coronary syndrome. Revascularization happens to be the mainstay of therapy. If there is a ventricular tachycardia in a person who has been doing very well after he had survived the old myocardial infarction, is usually the re-entry. Drugs and revascularizations don't help much. AICD happens to be the mainstay of therapy. We all need to know how we identify the triggers, and we all need to be knowing how do we identify the scar, how do we identify the propagation of the wavefronts of these tachyarrhythmias, because if we become more and more confident in dealing with such kind of a ventricular tachyarrhythmia by simple procedures like radiofrequency ablation, and maybe very soon we may get some good drugs. So with those drugs and radiofrequency ablation, we might even find a day where defibrillators are used less and less because they come with a cost and complications. So it is very, very necessary for us to understand ischemic VT so that we can save our patients from developing sudden cardiac death. So with this, I would like to end my talk, and I would like to again thank everybody in APHRS who gave me this opportunity to talk to you people this morning. Thank you.
Thank you, Dr. Pandurangi. It's a very comprehensive and interesting talk. So I can see here we already have some questions, but we will discuss it later. So without further ado, I will move to the next speaker. Ms. Suvan Liang. She is the APHRS certified for the EP and cardiac device. Currently, she works at National Heart Center, Singapore, since 18 years ago, isn't it? And this morning, Ms. Liang will talk about how to do a good preparation for patient undergoing VT ablation. Please.
Thank you, Dr. Yoga, for the kind introduction. Okay, I'm going to try and share my screen here. Okay, so today the topic given to me was how to prepare a patient for VT ablation. So as Dr. Pandurangi has already talked about what are some of the VTs we encounter in the lab. They could be just PVCs that we do ablation for, this patient might have normal heart structures, and they are usually automatic or trigger activity from the RVOT or LVOT, and they can also be re-entry skull-related VTs. And these patients are actually usually more sick with structural heart disease, as they have ischemia and other things. So what are some of the reasons to ablate them? They come into the EP lab would be they have symptoms which are not able to control with medication. The medication might be effective, but there's unpleasant side effects. Or there are patients with devices. The devices are life-saving, but in the end, they experience very frequent shocks. And even with the shocks, sometimes they are not able to terminate the VT with all these therapies. And some of the patients with biventricular pacing, they have PVCs that are too frequent that it impedes their biventricular pacing synchronization therapy. So these patients come into our lab for ablation. So I will talk about the normal PVCs that are from the RVOT, LVOT. These patients are very well. They have normal heart structures. And so usually the preparation is not much. So before the procedure, for me as a EP tech, we will look at the 12-lead ECG for localization so that we can compare whether it's from the right side or the left side of the heart. So we will know what sort of access we need to help the doctor to prepare. And then we look at the holters for the PVCs, how much percentage of burden there is, and how frequent it is, whether is it during daytime with activity. So if the patients come into the lab, there's not much PVC, maybe we can give isoprel to increase the percentage for mapping. Or is it more frequent when the patient is sleeping? So if that then is good, we can give lots of sedation and let the patient sleep. And then we can map the PVC. Okay, so for ECG localization, I will try to look at it, but I also actually make use of an app. So this is the app that I kind of use. It's called EP Tools. I use an Apple phone, so you can find it on the App Store. You might actually have to pay for it now. When I first downloaded it, you don't have to pay. So there are different ways that help you to identify where the focus is coming from. You can try to localize yourself looking at the ECG and then confirm it looking with the app if you want. Okay, so here we have for us when the patient comes in, we would immediately put on the 12-lead ECG for the patient, and then we try to see within the lab what is the morphology of the PVC that is currently in the lab. So this is what we do when the patient comes in. We save ECG, like you can see my mouse, and then we put it at the side for reference. Usually we do that and we don't really look at the 12-lead recording that is documented on when the patient is in the clinic, because the placement of the leads might be different. So we want to match the ECG that is happening now. So we capture and we save it, put a template at the side so we can do an easy matching of the morphology. So and then for our lab, usually we would have 3D mapping. So here you can see on the patient, we have the 3D patches. These are the cartoon patches. And then, of course, defib pads are very important because these are patients who can go, even though they have normal heart structures, they are quite well, but with ablation and manipulation of the catheters, they can easily go into arrhythmias. So be prepared to shock if you can. Then of course your indifferent electrode for ablation. And because we are doing something in the ventricle, monitor of the patient, we will have our saturation probe. And then of course for the monitor the patient's blood pressure, you have arterial line, or you can just not use a non-invasive monitoring, it's fine. And if a patient has got device, we will usually do a pre-procedure check. And if it's an ICD, we will turn it off before the procedure. So if nobody in the lab is able to check the device, we will have to arrange for the cardiac device rep to come in. So the amount of catheters we use would actually depend on the doctors. There are doctors who actually are just comfortable with one catheter to do the mapping because they find that there's less irritation. So if we have an RV catheter and a CS catheter and then an ablation catheter, sometimes the other catheters might be causing PVCs that interferes with your mapping, and then you have to look at whether is that the correct PVC. Yeah, so probably one catheter is easy. Another thing is using a different irrigant. So there's a paper that came out with different irrigant can result in different lesion size. So in our lab, we have a doctor which actually likes to use the half normal saline. So if you want to try a different, maybe let the technician know, then we can prepare in advance, because these might not be the things that are frequently available in the lab. So in this study, they compare the normal saline, half normal saline, and the dextro water to see, by using different types of irrigation for the ablation catheter, does it create lesions differently. So for the dextrose water, it actually creates a larger lesion, but also has a higher incidence of slip pops. For the half normal saline, it creates a larger lesion than the normal saline, but with the same amount of incidence of slip pops. So you can see here with the half normal saline, the lesion size is definitely larger. Yeah, so this might be useful for the focus that is intramyocardia or within the septum, or in places where it's deeper and harder to ablate, or when patients come back for repeat procedures. Okay, so if we are using 3D mapping, would the doctor want to have multilateral catheters? Then we will need to prepare for that. And in our lab, we have stereotaxis. Some doctors might prefer to have stereotaxis as less distortion in the anatomy during mapping, because stereotaxis catheter gives a maximum of 10 grams when we are mapping, so there's not much force to distort the anatomy during mapping. So what if when the patient comes into the lab, there is PVC but there's too little, do we not ablate then? So in our lab, we would try pace mapping also. If halfway through the procedure there's too little PVC, so we pace map. We have both ESI and CATO in our lab. So for ESI, we can use the score map to match the pace morphology and the patient's PVC, and in CATO, you will have PASO to help. Okay. As Dr. Pandaraji has talked about scar-related VT, very comprehensive talk there. So I'm not going to go too much detail into this. So the patients are usually sicker and their EF are very low heart function. They usually come in with VT storms. So these procedures might not be planned very much in advance. They are usually not elective. And they might also have LVADs. Later, I have an example of a patient with LVADs. So, and for these patients, usually they need more support during the procedure. More equipment are needed, and sometimes you need more catheters in different parts of the heart. And they require very close monitoring during the procedure. And as they are already might be quite sick when they come for the ablation. So before the procedure, we would try to know the patient history better by getting ourselves reading the patient's notes, and look at the latest echo and MRI to correlate areas of scar, and then of course look at the 12-lead ECG that has the documented VT to try to localize where it is on in the RV or in the LV. Is it likely to be endocardial or epicardial? If it's very likely to be epicardial, do we want an epicardial access at the start? So we would have to prepare for an epicardial access too. Then of course if it's LV and epicardial, you have to think about giving heparin and all that. And if the patient has got ICD with frequent shocks, sometimes we keep a copy of the device tracing of the VT, and during the ablation, we also, when we induce VT, we try to correlate the EGM on the device and the documented VT tracing and see if it is the same one, clinical one that the patient has experienced. But usually, you know, within the lab, the VTs that we induce are usually not the same. Very rare to get the same sort of VT. But this is one thing that you can do. So you turn off the therapies, but you keep the detection on so that the tracing can be safe and seen on the programmers. So for these very sick patients, usually we try to arrange for anesthetic support, and especially if their VTs are unstable, they are hemodynamically compromised. And for the heart failure patients, if they have LVAD, sometimes we get the nurse to come and support the device during the procedure, just to stand by, and of course reprogram the device if the patient has any. Usually they would have CRTs or ICDs. So the preparation part for the patient would be about the same, but like I say, a closer monitoring. So instead of just a BP cuff, maybe we want to have arterial line BP monitoring for the patient. Then of course 12-lead ECG, defib pads would be very essential in this case. Your mapping patches, device checks. So again, usually we discuss with our doctors what sort of access they need, which part of the heart they are going to map, and then we would prepare for it. So if they are going to the left side of heart, are they going to do a retrograde aortic approach, or do they want to do a transeptal? So then we have to prepare the transeptal stuff. Or would they want to do both? Some doctors would like to do both because certain parts of the left ventricle would be difficult to assess with just a transeptal, and with a retrograde aortic approach, sometimes you cannot assess certain parts, which would be easier with a transeptal approach. So usually for scar-related VTs, we wouldn't do with just a single catheter. We would usually put a RV catheter for pacing or induction. And then we'll put in a CS catheter unless the patient has got a CRT. In this case, you might be afraid that you would dislodge the CS lead. And then, of course, 3D mapping for the patient if the doctor would like to have. And actually for multi-electrode catheters, mapping scar-related VTs has been very, very useful, as we have seen now. So what sort of maps that the doctor would like to acquire, they usually would discuss with whoever is doing the mapping, whether they want a scar map, maybe an ILAM, the isochronal activation map. So this is mapped with pacing or in sinus. And then eventually, would we want to induce VT for the patient? And is the VT of the patient hemodynamically stable? Then if it's stable, do we want to have activation maps done? If it's not stable, then we have to make do with just the scar map or the island map. Okay, so now I will go through some of the cases in our lab. So this is actually quite a nice case. So this patient is actually just PVC ablation. So the patient came into the lab. Patient is male and 69 years old. Patient has got CAD, coronary artery disease with previous PCI, but EF is normal. So patient doesn't have a device because EF is normal. And patient has got very frequent PVC on Holter, and I did not type that wrong. Burden is 60 to 70%. Later when I show you the ECG, you can see. So ablation has been done before in January, but PVC recurred. So this is the ECG. You can see PVCs and salvos, couplets is definitely more than the patient sinus rhythm. So I tried to localize it on my own. It has got a right bundle branch block morphology, so it's on the left side of the heart. And AVF is called the superior axis, but it's very shallow. It's not very deep. So it's not from the basal of the heart. The one has got the RSR pattern on the lateral side. So I use my app to correlate. So it says it might be on the anterolateral mitral annulus. So then we can go and map and see. So the catheters we use for this case are the CS catheters. CS catheter, RV catheter for pacing. We use HD grid in this case, and then for ablation we have the TactiCath SE, DF curve. We use a transseptal access for this patient, and the shift that we use for the transseptal is the Agilis shift. So you can see with the CS in, it's definitely on the left side. The CS12 is the earliest ventricular activation here, but is still a bit away from the onset. And on the grid, you see these very, very nice signals here. So we decided that's where it is. And here, this is the this is an activation map. This is a PA view. And you can see it's here, the earliest. So for ESI, white is the earliest, and then it goes to red, orange, yellow, cyan, blue, and then purple is the latest here. So this is LRO view. So I try to put in the anatomy to let you see where it is. It's near the anterior lateral, just behind it, pec muscle, anterior lateral pec muscle here, just behind it. And we put in the ablation catheter, and we managed to see it on the ablation very early, minus 33 milliseconds here. And so one thing about the TactiCath SE is that the holes are actually evenly spaced, and they are 2-2-2 configuration. So you can actually put one. So you can see here is a distal, mid, and proximal. So this is actually 1, 2, 2, 3, 3, 4. So if you put all these 3 poles, you can see where exactly the good signals are. If it's more proximal, probably you can pull back your catheter a bit. And if it's in the mid, as you know, ablation is at the tip. So you want the good signals to be at the tip rather to be near the proximal or the mid. So this is eventually where we ablated, and you can see immediately there's a cessation of the PVC. So it was really very nice, because before that the patient was really having couplets, salvos, more PVC than sinus. So these are our ablation points. Because this is the patient's second ablation, so even though we managed to get it on the first few burns, we have to do like a bonus RF around the spot. And so this is post ablation, very nice sinus rhythm for the patient. So the next patient is slightly more complicated. Patient has got inferior STEMI, And then PCI was done for the patient. Then patient developed VT storm. After that, require multiple times of multiple shocks. And then patient came in for substrate modification of VT ablation. But during that first ablation, the VT wasn't easily induced. So we did substrate modification. And even after that, the ablation, the VT was not very easily induced. So patient was discharged, and then ICD was implanted then, because this is a secondary prevention. So then 2 weeks later, the patient came to the hospital again for recurrent appropriate ICD shocks for VT storms. So EF by that time is about 40, 45. And because patient just had a ablation 2 weeks ago, so we gave more medication to control the VT. And at the end of the month, when the patient came in for device check, patient actually went into VT during the threshold testing. And however, this appropriately detected and terminated with ATP, anti-tachy pacing for the patient. So we electively list the patient for a second procedure. And during this procedure, the VT was localized to apical septum and intramurally. So even at the second procedure, we weren't able to get to the focus of the VT. So our decision was to bring the patient back the third time to do an embolism of the distal RPDA. So here, let me show you. This is our map, propagation map of the VT. As you can see, it starts here in the septum apically, and then it spreads out, activating both the ventricles at the same time. So we have ablated multiple times at the area, but the VT keeps coming back. Okay. So this is actually the first time our lab has tried this procedure, because the 2 previous ablations didn't work. So we put in a wire into the coronary. So the wire that we use is cyan blue wire, and then we use, so for wire, the entire wire would be picking up signals. What we can do is we need to isolate the wire to look at signals from the tip of the wire. We use a microcatheter, ProGlide, to insulate the rest of the wire. And then of course we have an RP catheter here to induce VT if we want. So for this case, we have to collaborate with our interventionalists to do this procedure. So a lot of collaboration for this. So you can see this is a angiogram done. Basically, this is a coil before it's deployed. So there's still flow going through here. So we managed to induce the VT, and this is the signal from the cyan blue wire here. And we never see this signal during our mapping. We were never very early when we were mapping endocardially. So you can see how early we were here from the wire. So how do we put on? We put it as a unipolar, but here we put bipolar because we have an indifferent electrode in the IVC. That's why we get such a clear signal on the wire. So for unipolar, you can actually use the Wilson central terminal, but sometimes when we use that, we realize there's a lot of electrical noise. So using an indifferent electrode in the IVC makes it not so so much artifacts. And then these are the settings. And then pace map from the wire, you can see it matches almost 12 out of 12. So this is the nearest to the focus that we can get. And when we do inject cold saline into the coronaries, the VT terminates. So this is like a test. So this has been done before. We are not the first one to do. Yeah. So this has been described before. So this is like after 2 ablations and we couldn't get, this is something that we thought we'll try to see it helps for the patient. So, oops, I hope you can see, because for my screen, it's actually blocking the, okay. You can see that is blocked now, it's occluded, so the coil embolizes this part and the flow no longer goes through. And so far, no more VT for the patient. This is actually last case. So this lady, only 42 years old female who's got an onset of non-ischemic cardiomyopathy 13 years ago, and then she has ICD implanted and LVAD implanted. So the patient developed a VT storm during one of her OGD procedure. Yeah. And then we couldn't get her out of the VT, so we brought her into the lab for VT ablation. And patient still has persistent VT after that. So eventually we also did the same thing for her, the coil embolism, and it worked. But I would just want to show her ECG. So this is her ECG when she came into the lab. She's in VT, as I say, because we couldn't get her out of VT. Every time we shock her, we pace terminate her, she goes back into VT. And one thing I would like to say about patients with a lot of devices on them, there's a lot of artifacts, and this is actually a characteristic of a patient with LVAD. They have a lot of electrical artifact on the limb leads, on actually almost all the ECG, and very low voltage. And this actually makes it very, very hard to do mapping. And you can see even on her normal 12 ECG, there's a lot of electrical noise interference from her LVAD. So with this, it's actually very hard to do pace mapping or morphology mapping, and even harder to see if the VT has changed. And at this point, actually, the VT has changed. We can only see intracardiacally the EGM that it has changed, but from the ECG, it is very, very difficult. So it's very complex to do this case, very, very challenging. Yeah, so be aware of some of the possible complications. The VT can become unstable, requiring defibrillation for the patient. So somebody really has to stand by, in the, a nurse to stand by in the lab. Then, of course, there are vascular complications, and for the access sites, cardiac perforation, and of course, thromboembolism if we are assessing the left side. Okay, so my conclusion is preparations for VT can be from very simple to extremely complex, needing collaboration from different disciplines, different departments. Then if it's simple, but when the patient comes into the lab, patient has got no PVC, so then we have to decide whether we want to try to give medication to make the PVC come out, or we have to postpone to another day when the patient has got a more frequent symptoms. So the complex cases would require more monitoring. Everyone to be more attentive to how the patient is, and because they're also subject to higher rates of complication. And if possible, plan the procedure in advance so that you won't be caught by surprise not having any equipment or need to troubleshoot stuff. Okay, that's all for my talk. Thank you for your attention.
Okay, thank you very much, Ms. Liang. It's very clear and detailed talk, I think, about the patient preparation and some complex cases you show us here. Yeah, it's very good. Okay. Okay, let's move to the last speaker, Dr. Agung. Dr. Agung is currently the consultant electrophysiologist from Primaya Hospital, Tangerang, Indonesia. So he will talk about the idiopathic ventricular tachycardia. Dr. Agung, please.
Thank you, Professor Yoga, for the opportunity. Actually, Professor Yoga is my teacher, so it's been an honor to invite to this talk in APHRS Live Professional Webinar. Okay, since I'm the last speaker, maybe I should go slow so the audience can follow. Okay, I want to talk this morning about idiopathic ventricular tachycardia. So, idiopathic ventricular tachycardia are commonly appear in patients with an anatomically and structurally normal heart with a distinct entity whose management and prognosis differs from ventricular tachycardia associated with structural heart disease. And this kind of arrhythmia usually emerge in relatively young adults, but also can happen in the older person, but most of them are benign since the morphology of the VT are mostly monomorphic. The tachycardia carries morphology on surface 12-lead ECG. Code predicts quite accurately the site of origin of the VT and is commonly classified as right ventricular tachycardia or left VT. And the patients generally tolerate tachycardia, and sudden cardiac death is rare in this patient population, maybe because the VT is most of the time is monomorphic. Treatment options include pharmacotherapy and or catheter ablation, and the prognosis of these patients remain excellent. So the mechanism of ventricular arrhythmia is due to triggered activity secondary to cyclic AMP mediated after depolarization of DADs. This increase in cyclic AMPs are similar to what happened during exertion or exercise. That's why most of the time the VT could be induced during exercise testing, and this explains this kind of VT is sensitive to beta blocker or CCB. So I want to show this ECG. This is male, 40 years old with palpitation. As we can see in this ECG is show relatively wide QRS tachycardia with RVBP pattern with superior axis. So what kind of this ECG is we can if we need this in the emergency. So we will talk about it later. So the recognition of the tachycardia is important practical value. So we must know how to distinguish idiopathic VT from SVT like the previous ECG. With aberration, since treatment will be very different. This will also help determining ablation strategies and logistic need to diminish this VT or just do pharmacological treatment. So to classify the idiopathic VT, classification is respect to the origin of VT, right ventricular VT or left ventricular VT, the VT morphology, left bundle branch versus right bundle branch. Is it response to exercise testing? Is it response to pharmacological agents like adenosine sensitivity or verapamil sensitivity or propranolol sensitivity, and the behavior of VT? And last is the morphology of VT. Is it monomorphic or polymorphic VT? So most of the time we classified VT based on topology or location of VT, since it will help us to make the best ablation strategy and raise their confidence for doing it. So the classification is orphanomorphic idiopathic VT is outflow tract VT, aortic cusp VT, LV VT, annular VT consists of mitral and tricuspid annular VT, or the other form of VT like the body of right ventricle or crux of the heart. So most of the VT are outflow tract ventricular VT. So outflow tract ventricular VT is predominantly localized in and around the right and left ventricular outflow tracts. The OTVT are the most common form of idiopathic VT. It is originate in more than 80 to 90% of cases from the right ventricular outflow tracts especially. They manifest and come to EP doctor at relatively early age, like 30 to 50 years old, range 6 to 80 years. The equal distribution between sex in left ventricle outflow tract VT, VT, whereas right ventricle outflow tract is more common in females. So what is the relationships between LVOT and RVOT? In this picture, we can see that RVOT and LVOT is side by side, and RVOT is bounded by pulmonary valve and superiorly, and superiorly aspect of the tricuspid apparatus inferiorly. The RVOT is leftward and anterior to LVOT. So this is where LVOT is a region of LV between anterior cusp of mitral valve and ventricular septum, consists of muscular and fibrous parts. And these pictures reveal the relationships between RVOT and the aortic cusp is very, very close. So the most important aspect of the relationship of RVOT and LVOT is that RVOT position is leftward and anterior to LVOT. So you can see in this picture, and the large parts of the right and some part of the left aortic sinus of Valsalva overlie muscular LVOT, close proximity to AV node and his bundle, mostly early activation of the VT. So localization of site of VT origin can be predicted using QRS morphology on surface ECG, and the anatomic relationships helps to explain shared ECG pattern and subsole differences. Like we can see in this quite modest algorithm, it could help us identify and location the origin of VT from the surface ECG. The algorithm shows that VT with LBBB morphology and inferior axis are right-sided origin, or a LBBB pattern with transition from a small R wave to large R wave at V3 to V4 shows OT side inferior axis. Whereas LVOT VT also could be LBB morphology with inferior axis with small R wave in V1 and early precordial transition, R/S more less than 1 of V2 or V3, KS or RS in lead 1, or RBB morphology with inferior axis and presence of S wave in V6 and V5 and V6. The Q wave amplitude in AVL is typically more than or equal to AVR. And ILVT show RBB pattern with superior axis either left or right. So the question is how we distinguish the RVOT or LVOT VT with V2 ratio. Betensky et al. At 2011 shows another methods to differentiate between RVOT and LVOT VT. He create a formula using a variables of R and S wave in surface ECG, especially in lead V2, that could distinguish the origin of VT. The formula is to calculate height of the PVCs, like we can show here, and sinus R wave and S wave, and then put is in this algorithm. So in this algorithm, Betensky score less than 0.6 considered an RVOT origin of VT. but the score above 0.6 or above are the sign on the VT are from LVOT. This score could help us to provide approach strategy and increase the successful rate of ablation, not to mention to the confidence while doing the procedure for the operator. So this is mentioned the Betensky that this method is much more accurate if the score preferred to RVOT PVC. Maybe because the RVOT PVC were more often than LVOT VT or PVC. So this is another way to distinguish anatomy location using this table. Using surface ECG patterns to pay attention to type of VT, where the axes are and lead V1 and V6, and other features of the waves are the critical parameters. These points could be useful to differentiate the location of the VT. So from this ECG, we can see that it is a VT, but which one? Is it a VOT or left or right ventricle idiopathic? Okay, this is the VOT anterociptal region. So this we can see that this is an inferior axis, and there is an left bundle branch block pattern and negative in lead 1 and AVL. So this is quite easy way to distinguish between RVOT and LVOT VT. The next VT, idiopathic VT, is idiopathic left vesicular VT, or most of time just called vesicular VT. Vesicular VT is natural history of the patient is relatively just like other idiopathic VT, is benign. Occurs in young, 15 to 40 years old, which is common in male. The symptoms include palpitation, fatigue, dyspnea, dizziness, and pre-syncope, but most of the time with hemodynamically stable condition. Most of the episodes occur at rest and can be triggered by exercise and emotional stress, and it's verapamil sensitive. The generation into VF is very rare, and hence the ACD is so very rare. The tachycardia-induced cardiomyopathy, although can occur, and spontaneous remission may occur with time. So the varieties of idiopathic left ventricular VT, vesicular VT, is left posterior vesicular tachycardia, DVB, and left anterior vesicular VT, with RAD and left vesicular bundle branch, and septal VT. So in the next slide, we will discuss it. The vesicular VT is due to re-entrant mechanism because it can be induced and trained and terminated by atrial or ventricle stimulation, but tachycardia circuit may comprise a macro re-entry circuit with posterior vesicle and serving as one limb, and abnormal decremental Purkinje tissue serving as the other limb. So the anterograde limb is composed of abnormal Purkinje tissue, which exhibits low decremental conduction, and retrograde limb consists of Purkinje system tissue for the left posterior vesicle. So this is the schematic representation of the intraventricular activation sequence during sinus rhythm in A, common ILVT in B, and after-septal ILVT in C. So in this sinus rhythm, impulse propagates anterogradely down to left posterior vesicle, giving rise to the P2. If you look at the pictures, then the activation goes from P2 to P1 at the point of fusion. Therefore, P1 is buried in the local ventricle activation. So we cannot see P1 very often. In common ILVT, during common ILVT, P1 and P2 are activated in reverse direction. So VT activation propagates anterogradely from the basal to the apical site. And in the upper septal ILVT, both of the left anterior vesicle and the left posterior vesicle are anterograde limbs of the re-entrant circuit, whereas the retrograde activation occurs via the abnormal Purkinje fiber at the middle septum. All the hypothetical circuits are demonstrated in the arrow position. The P1 refers to a specialized Purkinje tissue with a decremental property, and like I said, this is verapamil sensitive. And the red one is show us where the slow conduction is, and the dotted ones indicate the unsolved parts of the circuit. So for the conclusion of the LVT is it is very not too difficult to define the anatomic origin with this table. So we can see the KRS morphology and the KRS axis. So we can roughly tell us where is the what is the kind of the LVT. So back to the last ECG. The ECG was suggestive of idiopathic posterior vascular VT with wide complex tachycardia with QRS duration of approximately 120 milliseconds at a rate of 180 beat per minute with RBBB pattern and superior axis and left axis deviation. So the management of ILVT is excellent, has excellent prognosis, and the medical therapy is intravenous verapamil is effective for acute termination, and oral verapamil can be given chronically to control the patients with symptoms who do not wish to pursue or undergo catheter ablation. And adrenergic blockers have also been used with some success. But if the patient willing to undergo catheter ablation, the successful rate reached nearly 90%. So there's other way of idiopathic VT. So Van Herendel in 2010 published a paper that he registered among 278 patients who underwent ablation for idiopathic VT or ventricle premature depolarization or PVC arising from the right ventricle. 10% had VT or PVC from lower RV, 48% coming from the tricuspid valve annulus, 28% from the basal, and 24% from the apical segments. And among the tricuspid valve annulus, 57% is from free wall and 43% from the septum. So this is the number of other than LVT and RVOT, RVO2 or LVOT VT. So VT arising from the metal occlusive annulus is called the annular VT. It accounts for between 4% and 7% of idiopathic VTs. Most often they are of repetitive phonorrhotic type, and they behave similarly to outflow tract VT, and the prognosis and the drug response is quite the same character. And the annular VT is amenable or can do catheter ablation. So we talk for emitter annular VT. The RBB pattern or transition in V1 or V2 are quite distinguished character for interannular VT. And S-wave are V6 and monophasic R or S in leads V2 to V6. And the further classified mitral annular VT into three categories depending on the site of origin. There is anterolateral mitral annular VT, 58% of the mitral annular VT, and posterior and posteroseptal mitral annular VT. And there is also tricuspid annular VT. There is only 8% of the idiopathic VT, 5% of right-sided VT. So septal location, anteroseptal or parhesian location is most commonly found. From the ECG, a positive component, any R or R, was recorded in lead AVL in 95% of patients. The radiofrequency catheter ablation was very successful for free wall, which is reached 90%, compared with the septal to only 50% of the group. The low success rate in the septal tricuspid annular group was due to the likelihood to compromise the AV nodal conduction because it is very close to the AV node and his Purkinje system. So this is some picture that shows that most of the VT are different due to locations of the VT. So you can see there is various morphology in V1, V2, and V3 in the different site of the location of the VT. So if we talk about VT, so what is the management of the idiopathic VT? There is three large management in VT. There's an ablation, of course, and pharmacological, and then CIED. So what the guideline says, the 219 expert consensus, APHRS, APHRS, and LAHRS tells that in patients with symptomatic ventricular arrhythmia from RVOT, catheter ablation is useful. The level of evidence is 1D. And how about the non-outflow tract ventricular arrhythmia in the absence of structural heart disease? So, in patients with symptomatic ventricular arrhythmia from RV at sites other than outflow tracts like tricuspid annulus, moderator vein, parietal vein, or papillary muscles, which are anti-arrhythmic medication are ineffective, not tolerated, the catheter ablation is useful. So the catheter ablation is one of the modality that useful to treat the ventricular arrhythmia. And what about from the LV sites? The LV sites other than outflow tract is also useful to do the catheter ablation. So maybe Ms. Sufen Liang has tell us how to prepare the VT ablation. So I will just make it simple. So the tools are for the ablation. First, we have to know the surface ECG to distinguish what kind of VT we deal, and then we can do a pace mapping, do an entrainment technique, and we can do a 3D electroanatomical mapping. So this is 3D anatomical mapping, maybe Dr. Ulhas and Dr. Ms. Sufen Liang is also explained in the previous presentation. And then what is role for ICD? So ICD in presentation is recommended in patient with documented VF or hemodynamically not tolerated VT in the absence of cause within 48 hours after myocardial infection. So the ICD has a place in some kind of VT that has a hemodynamically compromised patients. And beware of the another differential diagnosis that could show an outflow tract ventricular arrhythmia morphology such as IRVC, CPVT, Brugada syndrome, and idiopathic polymorphic VT and VF. So for the summary, idiopathic VT occur in structural normal heart, and ECG is very useful for determining the origin of VTs. And most idiopathic VT come from outflow tract, and most of it come from RVOT. So understanding of ECG characteristic of idiopathic VT, mapping for ablation will be more focused to specific site. And always think of differential diagnosis of rare idiopathic ventricular tachycardia. Thank you.
Okay, thank you very much, Dr. Agung Chandranegara. So we already hear how to differentiate the VT from other wide KRS complex tachycardia from the ECG. I think it's very detailed, has been taught by Dr. Agung. So now we are going to have some discussion on some question that has been addressed to speaker here. And let's now have some QA. Here we already received 5 questions. I think I would like to start first with Dr. Pandurangi. Here we have a question about how much relative risk reduction can be achieved by implanting ICD for second of primary prevention. And I think it can be combined with the second question, how to make more effective in patient selection, especially for the primary prevention. Dr. Pandurangi, please. I think you have to unmute your...
Right. So I think these are the 2 excellent questions, which are actually bothering the physician group. And I'm glad that, this question is even raised by our colleague allied professionals. Because you see, the entire science of ischemic ventricular tachycardia or ventricular tachyarrhythmia is towards to make the defibrillator therapy to take a backseat. And that comes with a cost and its associated complications. But unfortunately, we do not have any definite means as of now, which will definitely protect the person from sudden cardiac death. Defibrillator seems to be, the strong choice. But then we got to address some scientific questions here. And these 2 questions are, I believe, are very, very scientific. And that is what is the whole, the science development issues. So when it comes to the relative risk reduction by secondary prevention, as compared to the primary prevention, I have got to make 2 comments. There is a less debate about the magnitude of the relative risk reduction when we talk about the secondary prevention. That is significantly high without the defibrillator, both with respect to the prevention of sudden cardiac death as well as prevention of total mortality. Secondary prevention, relative risk reduction, based on some of those old trials like AVID, CASH, and SIDS, it's approximately 50%. And when it comes to the primary prevention relative risk reduction, it is far, far less. It is less than about 10%. And when you talk about how many patients with the primary prevention AICD tend to ultimately get appropriate therapy for or appropriate shock for ICD, it is far less. It is less than about 10%. Maybe it increases little more if you follow up these patients for long. And one should also remember that if you really look at the shocks, those patients who develop for the primary prevention may far exceed with respect to inappropriate shocks. So we should remember, if you take only shocks, well, it may be appropriate or may be inappropriate. So primary prevention ICD therapy, appropriate shocks, the people getting benefited is far, far less. It is maybe less than 10%. So the problem here is, I'm going to extend that question because the person is asking me how to make it more effective in terms of patient selection. So how to make this primary prevention benefit really more applicable to those people, at those regions where social and economic situations are not favorable. For example, typically many of the Asia Pacific countries. The whole science and the whole trials are looking into this, but unfortunately, whenever you conduct a trial to increase the benefit of the primary prevention or the case selection, the problem is to conduct a trial is becoming extremely difficult because of the guidelines which are being set. The guidelines strongly recommend less than 35%. You do not have to have a PVC even for an ICD. When you conduct a trial, you need to follow the guidelines which are being set. So unfortunately, ironically, paradoxically, the set guidelines itself is a major detriment to find out how to make a proper or a better patient selection group. So, we are in that problem. So it is a difficult task presently to find out which is that patient population who could be actually better off with the primary prevention than the set guidelines. So I hope these few ideas of mine help the person to understand the answers.
Okay, thank you very much, Dr. Pandurangi. So I think this is our problem in this region. I think with some or majority of the country with, let's say, not that very well, then primary prevention become a big concern when we have to put the ICD in this kind of patient. Okay, let's move to the next question. I think this one, I believe, for Ms. Liang. So would you like to explain again about the EGM recording using PCI wire, the beneficial and how to set up properly? I think you saw one case with that, yeah?
Yes, can I share my screen so that I can show the...
Yeah, sure.
Okay, in this case, we use the PCI wire because we already suspect the focus of the VT is near, the site is near where the coronary is. So we use the Sion blue wire for this because it is something more comfortable for the interventionalist. Otherwise, you can actually use, Biotronic actually has got a wire called the vision wire, which has a metal tip with the rest of the wire that's insulated. So you can see signals from the tip of the wire. But if you don't have that, another way is to use the normal, just a normal PCI wire, and then you insulate the rest of the wire with a microcatheter, so that you can only see signals from the tip of the wire. So as you move the wire along the coronaries, or you can even use it in the CS, I guess, if you suspect it's near the summit. And this is actually, so if you are looking signals from the tip of the wire, it's actually a unipolar signal. So, but the setting, so I'm using a GE system here. My settings, I am still choosing a bipolar signal because I have an indifferent electrode in the IVC. So what I do is I'm seeing the tip, which is I put at 1. So you have to sort of like a jumper cable from a crocodile clip onto the wire, and then a pin which you plug into the junction box. So this 5 on the junction box is connected to the catheter that is not within the heart. So we place it just at the IVC area. And the filter settings is for unipolar. So for the G system, and I suspect for the other recording system, if you choose unipolar here, it might, you will have to choose the Wilson central terminal. So automatically your negative input here will not be able to select. You can only select one. And that one has got a lot of noise artifact. So this would be a better choice if you want to have a nice unipolar signal. You can even use this for your ablation signal if you want to see unipolar from the first electrode. So ablation 1. So sometimes we put as that. And then you put the positive input as 1, ablation 1, and then an indifferent electrode. It can be at any pin on the junction box. And then the filter settings is as such. So it depends on what recording system you have. For GE, the filter settings are quite limited. So these are the sort of settings that we have. Is that okay?
Okay, I think that's very clear. I hope that Mr. Ian can understand that one. So let's move to the next question. This is for Dr. Agung. So the question is, if we found the patient has idiopathic VT, let's say from RVOT, but the ECG show very wide QRS with pseudo delta on precordial lead, that we assume it's coming from epicardia. What should we do? Dr. Agung?
Yeah, okay.
Please.
Thank you, Professor Yoga. As I say, the ECG is the most useful modality that we could use to build strategy for ablation and then targeted specifically point of the ablation. But as from epidemiological data that most VT are from the RVOT, and since the ECG shows RVOT region, I personally think that we should go for endocardial mapping for the RVOT first. And from my opinion, we should use the 3D modality if we could afford, a patient could afford the procedure, because as we know, with the 3D procedure, we could accurately pinpoint the ablation target. But then again, that not every place could easily afford the use of 3D ablation. But of course, the epicardial ablation should have crossed our mind if the delta of PVC are there. So I think that's my opinion. That's my answer.
Okay, thanks, Dr. Agung. I think the last question, I think I would like to address this to Dr. Pandurangi. In case of a stable VT patient, suspected scar related, a site of ICD, is site of exit pattern from ECG do matter in choosing antiarrhythmic preferences? Dr. Pandurangi?
So, it's a very, very interesting question. We wished we had some knowledge like this, but so far, we have only empirical two drugs. Those are the amiodarone and sotalol. They have not been studied extensively whether a particular ECG morphology is effective for, say, amiodarone versus sotalol. Not really. There is no such drug which could be prescribed on the basis of the QRS morphology, which is telling the site of the exit. I think, it's a great concept. Maybe some trials, some observations need to be, coming out. But when it comes to the choice of the antiarrhythmics, there can be one situation, and that is if, for example, a VT storm, where you are thinking about the so-called automaticity and the triggered activity. Well, you can always use the conventional ones, but then mexiletine has been typically shown in a limited data with respect to the triggered activity. Maybe it is effective, but not necessarily superior to something. So I think it is an interesting concept, but as of now, amiodarone, following which sotalol, mexiletine in the hierarchy. There's no such data dependent on exit site.
Okay, thank you, Dr. Pandurangi. So we still have some question here, but due to the time constraint, I think we have to finish QA session by now. And now I would like to show you the result of the quiz. Yeah, Jimmy, would you like to show it? Okay, here we are. So I think the blue diagram is the pre-webinar answer, and the orange diagram is after the webinar. So we don't have a statistic value here, but you see here that I think there is a quite good improvement after the webinar in terms of the correct answer. So I'm happy with this result, I think. So I would like to thank to all speakers with for sharing with us their valuable expertise, and who have concern to enrich the allied professional knowledge in this region. I think please keep with us to encourage all the allied professional in this Asia Pacific region. So before I close the meeting, lastly, I would like to inform you all that the second allied professional webinar will be conducted on 18 July on 10 EM GMT plus 7 time, which is not so early for India and Bangladesh. So we are going to discuss a new technology of pacing, which is hedge bundle pacing, which the number of implantation in this region is increasing. And I think we need to be ready for this new technology, and we will discuss on it later on July 18th. So again, thanks for all the speakers and also for all the attendees and all that very interesting and important questions. Thank you very much.